Welcome back, Focus Learners, to another lesson. I'm your lead instructor, Harshal. Now, right off the bat, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Okay, let's dive right in. Today, we have a truly fascinating explainer lined up for you. We are going to decode the IPDRG system and explore the absolute anatomy of a healthcare claim. We're going to see exactly how precise clinical documentation isn't just about keeping good medical records, it is the direct driver of inpatient hospital reimbursement.
Here's our roadmap for this explainer. Section 1. Decoding the IPDRG system. 2. MDCs and the surgical split. 3. Principal versus primary diagnosis. 4. Severity, CCs and MCCs. And 5. Documentation case studies. Now, I know it's a pretty heavy hierarchical concept, but don't worry, we are going to unpack the whole shebang together.
Let's start with Section 1, Decoding the IPDRG system, the statistical foundation. So what exactly is a DRG anyway? Well, a diagnosis-related group, or DRG, is essentially just a giant statistical classification system. It takes hospital inpatient stays and groups them into categories that are expected to have similar clinical characteristics and require similar resources. The modern version we use here in the U.S., managed by the Centers for Medicare and Medicaid Services, or CMS, is called the Medicare Severity Diagnosis-Related Group. You'll hear it called MSDRG. It takes thousands upon thousands of possible diagnoses and procedure combinations and distills them down into roughly 750 distinct payment categories. It's like a massive sorting hat for healthcare claims.
It's actually really interesting to see how this system evolved. The original DRG was developed by Yale University way back in the 1980s, and it focused heavily on early grouping by just the principal diagnosis. Over time, it expanded. We got the IPDRG, which added pediatric and obstetric refinements. Then came the IPDRG, which brought in a 4-level severity scale primarily for state Medicaid programs. Finally, introduced around 2008 and used by CMS and most commercial payers today, we have the MSDRG. Its real claim to fame? It heavily differentiates cases based on severity and comorbidity. Moving right along to Section 2, MDCs and the surgical splits, the grouper architecture.
Okay, so the logic engine behind all of this, the system that assigns that final DRG, is called the grouper. And you know what? It operates in 3 very clean top-down logical steps. First, the principal diagnosis establishes the massive container for the claim known as the major diagnostic category, or MDC. Second, the case gets split into either a surgical or medical partition within that category. And finally, step 3, the secondary diagnoses are factored in to dictate the severity level. Simple, right? Let's look closer at that first step. The major diagnostic category is the absolute highest level of classification here. It is based entirely on the principal diagnosis and corresponds to a major organ system or etiology. For example, MDC-05 covers diseases and disorders of the circulatory system. Virtually all diagnoses are initially going to fall into one of 25 of these system-based MDCs, with just a couple of special carve-outs, like MDC-26 for multiple traumas or MDC-27 for HIV. Once that MDC is set in stone, the grouper makes a hard split. Cases are partitioned into a surgical partition if a procedure is present that meets the very strict CMS definition of a major operating room procedure. On the flip side, if no major OR procedure was performed, boom, it automatically goes into the medical partition. This single split fundamentally alters the entire trajectory of the claim. All right, Section 3, Principal versus Primary Diagnosis, the clinical anchor.
Now, this is a crucial point, and it's where a lot of folks get tripped up. We have to understand the difference between these two easily confused terms. The primary reason for admission is simply the chief complaint that caused the patient to walk through the doors on day 1, like, say, severe chest pain. It's great for tracking, sure, but it does not determine the MSDRG. The principal diagnosis, however, is the condition established after study to be chiefly responsible for occasioning the admission. So, while the primary reason might have been chest pain, after all the tests and labs, the principal diagnosis is established as an acute myocardial infarction. That after-study diagnosis is what determines your MDC. It's the anchor that drives the entire claim.
Because it's so important, there are a few absolute golden rules of coding to keep in mind here. The principal diagnosis is always coded first. Also, the underlying condition is always considered the principal diagnosis. And guys, pay close attention to the massive difference between 2 incredibly similar phrases. Rule out means the physician suspects the condition and it might be present on admission. Ruled out, with a D, means a condition is definitively not present.
This completely changes things depending on your setting. In an outpatient setting, if something is a ruled out, you code the symptoms. But for inpatients, we only code the established conditions. Moving to Section 4, Severity, CCs and MCCs, the multipliers.
So once we have our anchor, secondary diagnoses act as multipliers. They exponentially change the reimbursement tier. Almost every MSDRG has a triplet structure based on severity. At the bottom, you have the lowest payment tier without CC/MCC, meaning no high-severity secondary diagnoses were flagged. Then, in the middle, with CC, you get a mid-range payment boost, and right up at the top, if you have at least one diagnosis flagged as an MCC, you reach the absolute highest relative weight and highest payment tier.
Let's make this a bit more concrete. An MCC, or major complication and comorbidity, indicates high severity. Think conditions like sepsis or acute renal failure. A CC indicates moderate severity, like anemia or malnutrition. But here is the critical catch you cannot ignore. Present on admission, or POA, is a crucial indicator. If a secondary diagnosis like deep vein thrombosis happens during the hospital stay, meaning the POA indicator is N for not present on admission, it is considered a hospital-acquired condition. As a result, it often cannot be used to increase the DRG weight. In most cases, the condition has to legitimately walk through the door with a patient to count as a multiplier.
And finally, Section 5, Documentation Case Studies, Real-World Application. Let's ground this in reality, because looking at a practical scenario anchors us in the high-stakes environment of clinical documentation. Identifying a documentation issue, clarifying it with a provider query, and getting it corrected directly shifts the final DRG and improves clinical compliance. Let's walk through exactly how a before and after scenario plays out. Imagine a before scenario. A patient is admitted complaining of shortness of breath, and they have a history of diabetes. Now, vague documentation results in a principal diagnosis of pneumonia, unspecified organism, and a secondary diagnosis of type 2 diabetes mellitus without complications. The grouper takes this, crunches the logic, and spits out MSDRG 195, simple pneumonia without CCs/MCC. It's a low-paying DRG simply because the documentation doesn't reflect any high severity. But wait, let's look at the after scenario, where a clinical documentation improvement, or CDI team, steps in. After querying the physician and digging into the labs, they realize the patient was actually septic. So the principal diagnosis is changed to sepsis. Furthermore, that vague diabetes is actually specified as type 2 diabetes mellitus with ketoacidosis, which is an MCC. Suddenly, the result shifts to MSDRG 871, septicemia with MCC. Just by capturing the true clinical reality of what was already happening, the relative weight of this claim essentially doubles. It's a real game changer. So you see, it literally all comes down to the terminology used by the provider. Documenting a vague CHF or just sepsis leaves money and compliance completely on the table. But shifting to precise terminology, like capturing acute on chronic systolic heart failure or identifying the underlying shock component with septic shock, acts as a massive severity identifier. It correctly routes the patient into higher-paying, highly compliant DRG tiers. I want to leave you with a provocative thought to wrap up today's lesson. Does vague documentation simply cause a loss in hospital revenue, or does it actively misrepresent patient severity and trigger payer audits? Well, the reality is it absolutely does both. Mastering the MSDRG grouper logic isn't just some administrative exercise for coders, it is the essential language for optimizing financial outcomes while ensuring that a hospital's quality metrics stand up to scrutiny. Thank you so much for joining me on this deep dive into the anatomy of a claim. Keep learning, and remember, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Herschel. I will see you in the next explainer.